it's great to see you all. We were expecting 36 people on this call, including a number of people from different parts of the world and from different clusters. And of course, they may still join us. So what I'm going to talk about now, I have to say to the current audience that I'm looking at, it's going to be very, very basic, and you already know a lot of this. However, I'm going to continue exactly as I was planning to, because we're recording this, as Brian's just said, and we will therefore have a large number of people afterwards who will be able to listen to this. So drink your strong coffee and listen to some basic information, and then we'll move on to David giving us some profound insights into the cardiology side of things after I've said just a few words. Non-communicable diseases, what an exciting term, isn't it? You know, it's like primary health care. It just really gets us sort of off our chairs with a thrill. But of course, it's not a very exciting term, but it is a very, very important thing. And we're going to be looking at 5 main NCDs. Unfriendly things like high blood pressure, diabetes, being overweight, not getting anybody to stand up at this stage, it'd be too embarrassing. I know I'm sure everybody here is taking very good advice already on these things. Not having enough exercise is the 4th thing, and of course having too much cholesterol in our blood because of all the delicious things we like to eat, which are not healthy for us. And as Brian was saying, 7 people out of 10 in the world will die from an NCD, which actually is 74% in fact. So that is pretty terrifying. And of all those 5 things I mentioned, high blood pressure is the most important. And many people are surprised. They say, well, you know, that goes on in wealthy countries. That's obviously, you know, but not in my country, which is not so well off. NCDs are the commonest cause of death in every country of the world. So this webinar is not just about interesting facts. It's about how you can prolong your own life, yes, yours, and that of your family members. Just a few personal words here. My father had high blood pressure and was overweight, and he had a very big paunch. I quite liked his big paunch, actually, but I didn't realize it wasn't very good for him. And then I myself developed high blood pressure and for many years enjoyed too much unhealthy food, and I also had high cholesterol. So as a result of this, when I was 55, I landed up in 3 different hospital intensive care units with heart problems, all within just 12 months. And the first time my heart actually stopped for half a minute and I had to be given an electric shock 3 times to come back to life. Enough about me. I want you now to think carefully about people in your family, parents, grandparents, uncles, aunts, brothers, and sisters. Do you or do they have any of these conditions? Perhaps a close relative of yours has died earlier than they should have, earlier than you might have expected. Do you happen to know why that's the case? Take courage. I'm going to now share some good news rather than some gloomy ideas, because there is so much we can do to prevent things from happening to us, and also how to reverse them if they have started to happen to us. 23 years after my heart stopped, I can now run an hour and a half non-stop up and down hills. So we can do a lot ourselves to live a longer life and a longer healthy life. And that's what we're going to be talking about today. And before I pass on to David, a few more key basic points just for us to focus on. First, to say healthcare does not primarily happen in hospitals. Healthcare largely should take place where we are in our home. We ourselves can do so much to reduce early death from these conditions, with all the grief that that brings to your family, your friends, your work, and your ministry. And the way we can do this is by one of the best words in the English language and in any other language: prevention. We can therefore eat healthily, keep to a sensible weight, take regular exercise, check whether we've got diabetes by using a single finger prick test, which can be available almost anywhere, and crucially know our blood pressure by having our own blood pressure cuff at home, or perhaps borrowing somebody's, or even encouraging our church to have some cuffs so that we can have our blood pressures taken after a church service. So many things we can do. So that's today's subject. Let's listen carefully, and I wanted to say finally, what we're talking about today can save your life and the life of those you love most. So I'll now hand over to others, and we'll think a little bit more and summarize things at the end. Thank you very much for listening.
Thank you, Ted. I am so convinced right now that you can run better than I can. And I love what you said, that prevention is one of the best ways, and that just knowing about how these diseases can affect us can save our lives. I want to move over to Dr. David. David is a consultant cardiologist, and he's based in the UK. He works both in private practice as well as the National Health Service. He specializes in the heart, but also has experience seeing patients with high blood pressure and cholesterol. He grew up in Eastern and Southern Africa and has since worked and traveled through Europe, Australia, New Zealand, the USA, Japan, and India. He is husband to Sarah Wilson, and Sarah suggested that I add, he is husband to the wonderful Sarah Wilson, who is Arukah Network's current network coordinator. And they have 3 children together. When he isn't working, he is a keen cyclist, guitarist, tennis player, and gardener. David, welcome. So good of you to join us today. Let me just unmute you, David.
Thanks very much for the great introduction, Brian. And thanks so much for the invitation to speak today, Ted and Sarah and everyone else in Arukah. It's a really great privilege. As you said, I did grow up in many parts of Africa. I tell as many people as I can that I was made in Tanzania. My parents married there. My sister was a young baby there, and I spent time in Sudan, Kenya, Zambia, South Africa when I was after school, when I was 18. And the only slight sadness of practicing medicine was that I was really quite passionate about cardiovascular medicine, and at the time there wasn't much cardiovascular medicine or a need for cardiovascular medicine in Africa. If you wanted to work in Africa, then infectious diseases was really the thing to do, with HIV and malaria being such important communicable diseases that needed treatment. And so now this is really the very first time I've had the opportunity of talking about cardiovascular medicine to a sort of a non-UK, African-based and Indian-based audience. So it's really fantastic. And I hadn't also realised, Ted, your cardiovascular background. That's very interesting. Sort of on the same theme, my father also has a paunch, has lived life very well, has high blood pressure, has had a high blood pressure really since the age of 40, as far as I can recall. His father had diabetes and a pacemaker, and my father ended up having a heart bypass in Bordeaux in France about 10 years ago. I am borderline, depends which country I'm in. If I'm in the UK, I don't have high blood pressure, but if I was a US citizen, I would be classified as having high blood pressure because their thresholds are a bit lower. And I'm not sure if I've got high cholesterol, but I've had my cholesterol checked this morning at the GP because it is important to know your cholesterol. So even though I'm a doctor in cardiovascular medicine, you obviously, as Ted said, prevention is important. You need to know, you sort of look after that part of your health as well. So even though I look, or people tell me I look relatively young, I have been a doctor for 20 years and been a practicing cardiologist as a consultant in the NHS for 7 years and been training in cardiology for probably another 10 years. So at least 15, 17 years of my life has been involved in cardiovascular medicine. And I wanted to share very brief overview of cardiovascular medicine with a bit of emphasis on high blood pressure. I have some slides I'd like to share with you. So I hope everyone can see this.
Yeah.
So this is just a map really to illustrate what is coming down the line to the world really in terms of non-communicable diseases. This is a map of the prevalence or how frequent high blood pressure is. And in the lower map is the prevalence of high blood pressure globally. And you can see that there wasn't a huge amount of change in blood pressure, except in the United States and Northern Europe. There's an increase in blood pressure. But you fast forward to 2019, and then most recently, you can see the rest of the world has now suddenly had a huge increase in the prevalence of high blood pressure, particularly in South America, the whole of Africa, Russia, and it's really quite a big problem, and it's actually relatively prevalent. So up to 30%, sometimes 40%, sometimes 50% of the populations of these countries have high blood pressure, and that's just one of the risk factors. We'll talk about more of the risk factors for cardiovascular disease later, but this is a massive problem. And
David, sorry to interrupt. We can't see the slides. If we could present, we can only see the first page. So if you could present, I think then we could be able to see the rest of the slides.
So if I say like this, can you see that?
Yes, we can.
Okay. So sorry, I'll just backtrack a bit. Thanks, Brian. So the map at the bottom here is a map of the prevalence of high blood pressure back in 1990 to 2019. And you can see it wasn't desperately prevalent except in North America and Northern Europe. And it wasn't changing a huge amount, but fast forward to 2019, there's a much bigger prevalence of high blood pressure. And this is just men, the similar picture for women, particularly prevalent in Southern America, Eastern Europe, parts of the Middle East, and in the Pacific Islands, where nearly 2 people in every 3 have got high blood pressure. But it's actually it's still very common in Africa, where 40% of people have got high blood pressure. So things are changing, and you will see over time that non-communicable diseases, particularly cardiovascular disease, is becoming more and more of an issue. One of the other things we have in the UK that you don't really have in Africa at the moment is we have a very elderly population, and with age comes increasing prevalence of high blood pressure, diabetes, obesity, and cardiovascular disease. So this is just a graph of the population globally in 2017, where you have a very wide base at the bottom of lots of young people. But fast forward to the end of the century, and you see this change, this increase in prevalence of older people with a smaller population of younger people at the bottom. So this is, in addition to the increase in prevalence of high blood pressure, this is going to lead to a big increase in the number of people with non-communicable diseases and cardiovascular disease in particular. So in the hospital that I work in, we see lots of cases of people coming in with complications related to non-communicable disease and cardiovascular disease. So this is a very typical patient. I was on call over the weekend, and I might have seen 6 or 7 people come into hospital with similar symptoms to this. So he's typically a 58-year-old male who's a smoker. He was told he had high blood pressure many years ago and recently been told he had diabetes, but doesn't like taking tablets. He wants to be free and wants to carry on living his life as normal. However, he was admitted to hospital with collapse and he had chest pain. And the pain people experience tends to be in the center of their chest. It tends to be heaviness, like a weight, like a car sat on them. They can't breathe. They feel sweaty, clammy. And the pain usually radiates to the left side and sometimes to their jaw. And he was diagnosed with having a heart attack. And in the UK, with people having a heart attack, we take them to an operating theatre where we look at we do a test to look at the arteries of the heart. And this is what we find typically. So we do this test called an angiogram, where we inject dye down this tube. You put the tube in the wrist, the artery in the wrist, and pass the tube up to the heart and inject dye down the tube. And this is the artery, one of the arteries of the heart, and you can see the dye coursing along here, but then it stops halfway down the artery because the artery should carry on all the way along here. You can see the outline of the heart here, and you can see the spine here and the ribs here. So this is a blocked artery causing a heart attack. And what the doctor has done here, they've passed a wire and a balloon through the blockage, and the blockage is usually just cholesterol. It's a clot, so lots of blood cells, and it's relatively soft. And so after they pass the wire down, they inflate a balloon to squash the narrowing, squash all the crud, so to speak, to the side of the artery. And then we inject the dye once again, and you can see the rest of the artery here that had been blocked is now beginning to open up and restore flow to the heart, which otherwise was being starved of blood and oxygen. And this is what we see at the end. So we see a nice big artery supplying a huge amount of the heart here, and without restoring blood, then this is a really life-threatening condition. So this happens quite frequently in the UK, and the sooner we get to treat this, the better. But how do people get into this state, and what increases the risk of people developing this situation? Well, there's a very simple mnemonic that I teach medical students when I see them, and the mnemonic is smoking fags causes heart disease. So smoking is one of the biggest causes of premature death. We've known this for decades now. Not only does it increase the risk of heart disease, it increases the risk of dementia, lung disease, lung cancer, poor circulation in the lungs. It's expensive and it's antisocial. So I don't know why anyone would inhale a flammable or burning gas into the lungs when you've only got two lungs. It's hopefully something that is going to, certainly in the UK, we're seeing less and less smoking, and it's a very preventable cause of cardiovascular disease. When they banned smoking in Scotland, and Scotland's got a really high risk of heart disease, immediately they saw a reduction in the rates of heart attacks. The F in the smoking factors cause heart disease. The F stands for family history. So there's a genetic component to heart disease, and there's not much one can do about that. But if it runs in your family, there's even more reason why one should be careful about the things they can prevent. And the other things they can prevent is high cholesterol. And as Ted mentioned, that's a blood test. And there are lots of different treatments now available to lower cholesterol in addition to lifestyle change. Sorry, this is not heart disease. This is high blood pressure. My apologies. So the H stands for high blood pressure, not heart disease. And high blood pressure, we'll talk about that in the next couple of slides. So high blood pressure is a really important cause of preventable death from stroke and heart attacks. And the D stands for diabetes. Diabetes is increasingly prevalent, just as obesity is increasingly prevalent, not only in the UK, but globally. I'm sure you've all observed that over the last couple of decades. So what I'd like to talk to you specifically now is blood pressure, because blood pressure, as I've mentioned before, is a preventable cause of cardiovascular disease, and it is associated with strokes, both bleeding within the brain and clots within the brain. It's associated with tearing of your aorta, tearing of your blood vessels, heart attacks, and heart failure, where the heart struggles to deliver the blood and oxygen it needs, or the body needs. There are two components of blood pressure. You may know a little bit about the numbers. The top number that we quote with blood pressure is the pressure that the arteries are under when the heart pumps. So it's not a constant flow of blood from the heart. Obviously, the heart is pumping, and the top number represents the pressure at maximal filling, if you like. The bottom number is the residual, the leftover pressure that there is in the circulation. And a normal blood pressure is 120 millimeters of mercury over 80 millimeters of mercury. And in different countries, they have different ways of recording that. So in France, they don't use 120 over 80. They use 12 over 8, and because that's using centimeters of mercury. So it might be different in different places that you live, but that is, broadly speaking, the normal or optimal blood pressure. Blood pressure can vary, and it varies enormously in the population, and it varies in health. So sometimes if it's the blood pressure can be too low, so less than 90 over 60 would be considered too low. And sometimes it's too high, so specifically high blood pressure. In the UK, we would say anything over 140 over 90, so it's either if it's 140 or if the bottom number is high. They don't both have to be above that threshold. We would say that is too high. In the US, their threshold is a bit lower, and they say if it's above 130, that's considered to be high blood pressure, which is why I mentioned that if I was in the States, I would be diagnosed with having high blood pressure. And sometimes the blood pressure can be really far too high. So if it's over 180, over 120, that's considered to be far too high. I had a patient admitted on Friday, and his blood pressure, I think, was something like 230 over 120, really very, very high. And the reason we have a picture of giraffes is because giraffes are really quite remarkable with their blood pressure. It's just worth just thinking about that for a second. They're huge giraffes, and they have an enormous heart that has to pump blood all the way up through their neck to their brain to supply the brain with blood and oxygen. But equally at the bottom, their legs, their blood pressure is enormously high, so 300 over 200. And when the giraffe bends down to feed, there are enormous changes in blood pressure as well within the brain. So the body is remarkable at its ability to cope with this, with a range of blood pressure. And you can be feeling absolutely fine in life, but have high blood pressure. You'd be storing up problems down the line. And that's why it's really important to check your blood pressure and check it so that you know whether it's within normal limits or too high. And if it's too high, you can take steps to change to reduce it. So what I'm going to try and do now is try and demonstrate to you all how to measure your blood pressure. So I will just unshare this. Sorry, where am I? And hopefully you can see me. So as Ted said, if you have a blood pressure cuff, that's great. And I actually have one. I bought one. So I lent my old one to my dad because he needed to check his blood pressure. And I thought I'd buy myself one the other day. So it's important when you're checking blood pressure, that the patient is sat down, ideally at a table, nice and quietly for about 5 or 10 minutes, feet flat on the floor, no real distractions, and that the patient is able to roll their sleeve up. There are different blood pressure cuffs available. This one is an automated, like a machine one, but there are lots of other ones where you inflate the cuff manually and someone listens with a stethoscope to what's going on. So you would have probably seen this all, but I'll just demonstrate it. You put the cuff on your left arm. It can be your right arm. They do recommend the left arm. You place your left arm at rest, normally on a table. The table's a bit far from me, so I'll just put it on my knee. And then you turn the machine on, and it's so easy, and you just press start on the machine. It's going up. It will get very tight, and then it will slowly come down over the next few seconds, and then it will tell you what your blood pressure is. Normally, it's a little bit stressful having your blood pressure taken, and so you should really check it 3 times, and you take an average of the last 2 recordings. And as I said before, so if it's above 140, the top number, or 90 being the bottom number, then that is considered to be high. If it's above 180, that's really very high. So if you notice someone in your community that has, oh my word, my blood pressure is very high. If you notice that your blood pressure, or someone in your community has their blood pressure that's very high, then really, if you have access to medical help, then that's ideal. But I understand in some communities that is not so easy. And we'll talk about in a second what you can do to lower your blood pressure without having access to standard healthcare or healthcare with the healthcare that I'm very familiar with, sort of access to tablets and whatnot, but there are different ways of treating it. So, as Ted mentioned, prevention is far better than cure, and there's lots of room for improvement, not within all our communities. So, talk in a little bit more detail about lifestyle changes that people can make, everyone can make, and everyone in this talk, as well as people in your own communities. So exercise. So the recommended minimal amount of exercise people should do is 30 minutes a day, 5 times a week. And that's a minimum. And in the UK, we're quite a sedentary country, and most people would struggle to achieve 30 minutes a day, 5 times a week. The definition of exercise is it can be going for a walk, but it's not a stroll. So it's a walk that you can't maintain a conversation at because you're working so hard. The more you exercise, the better the benefits. Weight loss is very important for several reasons. Firstly, it can lower your blood pressure, and it lowers, for each kilogram of weight loss that people are able to achieve, you can reduce the top number of your blood pressure by 1.5 millimeters of mercury, which sounds small, but if you lose 10 kilograms of weight, that's 15 millimeters of mercury. That is equivalent to 1 or 2 blood pressure tablets. And if you lose 20, that's 30 millimeters of mercury. That is a big change. So weight loss is very important for blood pressure. It's also very important for the risk of diabetes, because diabetes, or type 2 diabetes, is associated with weight gain and what we call resistance to your natural insulin. So to have it's at least a double gain, because also the more weight you lose, the more energy you have, the more likely you are to exercise, and it's a virtuous circle. Stopping smoking is really such a benefit for your health, and again, ideally don't start smoking, and not encouraging smoking for younger kids is so important. Diet is really very important as well, and there's lots and lots on diet, lots of evidence about diet. So specifically for blood pressure, there's a straight line association with the amount of salt in our diet and blood pressure. And we know if we reduce salt, we reduce blood pressure, and having a low salt diet is again equivalent to the benefit of blood pressure pill. So that's an easy win. And also certain fats, particularly processed foods, so foods that come out of a factory, that made in a factory, we would consider to be processed. And certain sugars, refined sugars, are associated with weight gain and the risk of diabetes in the long term. So all of those factors, if you really push hard with that, then you can really reduce the risk of cardiovascular disease and high blood pressures specifically. One other thing I would like to mention about weight gain is the risk of sleep disordered breathing. So sleep disordered breathing is where people who are overweight, their soft tissues cause compression of their airways at nighttime, and people snore, and snoring is not healthy. Particularly some people who snore, they can block their airways, and they can stop breathing transiently. If you stop breathing transiently, the body doesn't like that. The adrenaline surges in the body, and the blood pressure goes up, and the risk of high blood pressure and heart attacks and strokes really soars. So that the treatment for that again is weight loss. And it's if you're fortunate enough to have access to measuring your blood pressure, measuring your cholesterol, and also having tablets treatments, if those are available, that is also a great benefit, because in the UK and in Western Europe, we have seen our rates of death from cardiovascular disease being really very, very high in the 60s and 70s, gradually fall as a result of this screening program that we've had and treating high blood pressure and high cholesterol very effectively. So in summary, what I'd like everyone to take away from this is that non-communicable disease and cardiovascular disease specifically is a very prevalent and very serious condition globally. We're quite familiar in the UK about treating it, and I hope that I've explained a little bit about what can increase the risk of people developing this. You've seen a picture of a coronary angiogram and a blocked artery and the sort of consequences of that. We've talked about how to what blood pressure is, how it's high in some people, how it's low in other people, how to record it, and also some of the lifestyle changes that one can do to try and reduce the risk of high blood pressure and reduce the risk of cardiovascular disease in general. Happy to take any questions.
Thank you so much, David. Wonderful presentation, and the demonstration as well. I think that was really good because a lot of times we never know how these things work, but we also understand now that it's really crucial how we live our lives in order to prevent all these diseases happening. I want to mention that we will have a Q&A session towards the end. And so if you have any questions to that effect, just let us know in the chat and we will handle that towards the end. Right now, I want to welcome Christabel. Christabel is based in Benin. She is a nurse and she is a community health worker. She is really passionate about serving in the community, specifically with women in preventing and providing psychological support to survivors of gender-based violence. But she has also seen in her work the effects of non-communicable diseases in her community. And just in the next 5 or 7 minutes, she is going to share with us what she's been seeing and what has been working for her. So Christabel, thank you so much for joining us. Do feel free to
Thank you, Brian. Thank you so much. I am grateful for this privilege. I will want to share my slides so that we go. Let me just, can you authorize me to share this? Is it okay? Okay. Okay, thank you. Okay, thank you. So briefly, I'll be talking on the knowledge received and the realities on non-communicable diseases in low and middle income communities, especially in West Africa, where I find myself. As Brian has said it, I'm a nurse by profession. So the particular significance of this presentation lies in the thin line between the knowledge received by healthcare workers and the reality they face in the field when it comes to delivery of this knowledge. So this presentation will enlighten us on how to close up the gap to an extent. Permit me use this illustration. When we look at what is on the screen, I think everyone can see. When healthcare workers are on training, be it training as a community health worker or as a health practitioner in the hospital, this image is always one of the most common images that is used to talk about balanced diet. And when it is being used, the healthcare workers are being educated on, balanced diet has to do with green vegetables, legumes, calcium-rich food, fruits, whole grains, and other colorful vegetables, which is an amazing.
Sorry, Christabel, to interrupt. We currently are just seeing gray on the screen.
Really? Is it okay this way? Is it okay?
It's still gray. I suggest resharing it again.
Okay, I'll do that. Is it preferable?
So right now we're just seeing the folder with the documents.
Really? I have opened. All right, let me do another one. Is it okay?
We're still at the folder with the documents.
Let me reshare. Sorry about that.
It's fine.
Is it okay now?
Right now we're seeing your lovely face.
Oh no. So sorry. Is it okay?
Yes, perfect.
All right. Thank you. So sorry about that.
You're fine.
I want to. Okay, I was at this point talking about the knowledge received so far as balanced diet is concerned in school or on trainings that are being done so far as non-communicable diseases are concerned. Most of the time, healthcare workers are educated on educating the community to eat well in order to live a healthier life. And this is the knowledge they receive in their training. And so they have to communicate this knowledge to those they are talking to in the community. But it's just the knowledge they have received. Can you get me?
Yes, Christabel.
All right. This is the knowledge they have received. It is well canalized. And when they get to the community, it becomes another thing. The reality on the field is like you want to communicate something and the community begins to ask questions. How can this be feasible? How can this be a reality? We want to help the community in order to avoid some non-communicable diseases, but questions keeps coming up. We have the knowledge, but in the field, it's another sphere. Now, this is a community filled with its own belief system, with its own practices, with its own laws. And these same communities has limited finances. They have shortage of care services. They have social barriers that are largely driven by misconception. What am I saying? Some people believe that non-communicable disease is surely a spiritual force. And that's where their cultures and traditions comes in, that if it is a force, it therefore means it has to be taken care of based on a spiritual aspect. And it really becomes difficult for us to communicate that which we have to the community. So in September 20th, 2020, WHO notes that Africa appears to have the highest prevalence of hypertension in the world, amounting to roughly 46% in both sexes, so far as the communities are concerned. And another report comes up this 2023 in December from the Global Public Health Center on the prevalence rate of hypertension among people diagnosed with diabetes within the 5 geographical regions in Africa. And we can see the statistics as I've projected. We have, in East Africa, we have a percentage of 53%. In West Africa, we have a percentage of 51.5%, where I find myself. In North Africa, 63, in South Africa, 69, and with the highest prevalence rate in Central Africa. Now, this is the reality. West Africa has a rate of 51.5%. So these are people with diabetes and who are being diagnosed with hypertension. And the question now remains, with all this knowledge, how are we helping the community? What is our own contribution? Our focus in the community is the dietary approach. When I talk of the dietary approach, what do I mean? We are focused on diet. Reason being that West Africa has a lot of whole grains meal. And we know whole grains has a lot of carbohydrate. And so when they consume a lot of carbohydrate food, let me put it that way. We know the end product of it is glucose. So we see that this approach can really help our communities in order to prevent, as Dr. Tech said, and to also ameliorate those who are already in the situation. So I want to support that by saying, quoting a report still from a diabetes center who says, following a healthy eating plan is key to managing diabetes and hypertension. And also, managing blood sugar is the key to living well with diabetes, and eating well is the key to managing blood sugar. So how are we helping our communities using our approach? Firstly, when we get into a community through assault visits, we study the different types of foods that are found in the community. After studying the different types of foods together with the community, we see how to help them prepare different dishes at a cheaper and affordable price. Thirdly, we continue with a monthly monitoring of blood pressure and blood sugar, because we do a SWOT visit at monthly basis. So when we get there, this is what we do. And at the end, we encourage them to continue monitoring their blood pressure, their blood sugar before taking their medication. I would like to emphasize here by saying that we are already in the community working on menstrual hygiene, menstrual and sexual health management. So this enables us to better communicate to the community what these non-communicable diseases are all about. So this approach helps us to help the community. Thank you so much for your kind attention. Thank you, Brian.
Thank you, Christabel, for the presentation. It's really wonderful to know that in areas that have limited access to proper healthcare, that there is something that is done in the communities, and that it affects people of all ages and races. Thank you for sharing. Christabel, you can unshare your screen, or I can do it from my side. Thank you. Good, we're going along nicely. Again, if you have any questions, feel free to put them in the chat, and we can tackle them in the next couple of minutes. I wanted to give Robbins a chance to speak. Robbins is in charge of cluster development for our network, and I wanted him to share a couple of thoughts because he also has experience working with people who have gone through non-communicable diseases, and wanted him to share a thought or two before we got into our Q&A session. Robbins, welcome.
Thank you so much, Brian. I hope everybody can hear me loud and clear. I just want to start by asking a question. Do you know of anyone who suffers from heart disease or cancer? In layman's language, NCDs are diseases that are not passed from person to person. They are of long duration and are generally slow in progression, most of which are very, very expensive to manage and are currently claiming lots of lives globally. The rise of non-communicable diseases in Kenya, for example, and throughout the world, poses a threat to human health and a drain to the community. NCDs such as cancer, diabetes, and others account for 46% of the total deaths and over 50% of the total hospital admissions in Kenya. This warrants new approaches in prevention, diagnosis, treatment, and cure for such afflictions. Each year, more than 15 million people globally die from NCD-related ailments, and most of them are aged between 30 to 69 years. That's 85% of these. 85% of these are premature deaths, and they occur in low and middle income countries. A few years back, many people believed NCDs only affected rich people living in urban areas. From the data above, we've seen a sharp rise in the number of ailments and deaths that occur in low and middle income countries. Last year in November, just after 3 days of illness, a mother mysteriously lost her life in my community. Many people suspected she might have been suffering from malaria, which is a major killer in the sub-Saharan region. We later learned that she died from high blood pressure. After the burial, I had a conversation with some of my village mates, and we did a head count of the number of people we've lost in the last 2 years, majority of whom their deaths were NCD related. It is unfortunate that we are sitting on a time bomb, but doing very little to change the situation. Many people don't care if they are eating or care about whatever they are eating, so long as it is food they have on the table. What is important for them is they can fill their stomach, and they don't give much attention on the nutritional value or anything that they get from the food. In the countryside, it is very difficult to see people doing anything to keep fit, because majority believe that when they don't feel sick, then they don't necessarily need to take any checkup or anything to do with that. This is just an example, but you will agree with me that several countries, especially across Africa, are facing similar situations. In 2021, the Ministry of Health in Kenya launched a 5-year national strategic plan for prevention and control of non-communicable diseases. This strategic plan highlighted the increasing incidences of NCDs among young age groups and lower socioeconomic groups, while calling on prioritization of people living with NCDs in the second phase of COVID-19 vaccination, because most of them were quite vulnerable to COVID. Adoption of unhealthy lifestyle, including tobacco use, consumption of unhealthy diets, insufficient physical activity, and harmful use of alcohol will continue to claim lives if we don't act now. And if we look at direct economic losses, we also find that, for instance, Kenya loses about 430 billion shillings, and this represents about 7.4% of the NCD burden. The Kenya government estimates to have covered about 147.3 billion for those healthcare expenditures, and people from their households and out-of-pocket expenditure is estimated to be 132.7 billion. So you could imagine this kind of burden when put on your hard-earned labor and family resources that should have been used for other purposes are now used in treatment for things that we could easily prevent. Even though we have the government's goodwill, policies, and even plans in place to help avert the situation, very little activities or actions can be seen at the community level to help fight against the NCDs. And this is why we all have to come to the forefront to sensitize our communities, starting with our families and friends. Those who are very close to us are the people we start with, then we become living examples as we move out to reach out to other people. advocacy and campaigns through social media platforms, mainstream media, as well as one-on-one health talk, whether they are in schools or at the community level, will help change the perception. Also, health ministries and other stake players should incorporate strategies for reaching most at-risk population with correct information and actionable points and steps that will encourage positive lifestyle changes among the most at-risk populations. Investing in health promotion and primary prevention is thus a strategic approach in minimizing the cost of NCDs. And you'll also agree with me that NCDs are very, very expensive and difficult to treat when they have started to affect health, but much cheaper when we deal with the prevention at an early age, especially when we are still young. Let us focus and work on prevention rather than waiting to deal with the treatment later in our lives when it becomes very difficult for us to really fight it. Thank you so much for listening to me. Back to you, Brian.
Thank you, Robbins. I think what's standing out is just talking about the perceptions that we have and how we need to change them. And you said something that I picked about people not really caring what they eat. And I think this is just in line with what Margaret is also sharing, that when she spent her time in Uganda, she was amazed at the number, like the amount of oil that people use in cooking. And so directed to Christabel, she just wants to know that if she's found that the visits being helpful, because that's one of the ways that we are helping the communities, is just going to them and talking about how meals are important, how to prepare the right meals. So Christabel, if you're around, we would love to know more about that and if you've seen any changes using that approach.
Okay, thank you. Thank you so much. Actually, the approach in the field is not really like, we do not come directly to say we want to talk on your meals, but we come to help them economize. We come from the perspective of economizing your incomes, because we realize that most women prefer buying food in the morning, and even during lunch, they prefer buying food to give to their children. So we came with the approach of encouraging them to economize and cooking the food in their homes. So at the beginning, it was a little bit difficult because that mindset remained. At the beginning, it was difficult, but with time, they understood, first of all, that it is economical to prepare their own food. And secondly, we encourage them to prepare the food according to what they have in their environment in order to eat healthy. Because as the person said from Uganda, there is a lot of oil, a lot of starchy food. So the people are being encouraged to use that which they have in their milieu in order to prepare a healthy meal. So it's actually progressing gradually and people are integrating into it and it's moving on. Thank you.
Thanks, Christabel. And David, you can just jump in with, do we have any specific meals that when we just finish this call that would be really good for people to take on that they haven't, that can help?
It's a slightly difficult question because it's so dependent on what's available for you. In the UK, what I tell my patients is based on when in cardiovascular medicine we do a lot of trials where we test different treatments and different diets to see if they make a difference. And one of the diets that has been tested is called the DASH diet, which is essentially a Mediterranean diet. which consists of legumes, grains rather than pasta and bread, lots of fresh fruit, vegetables, fish rather than red meats. That kind of diet is preferable, and it does has been proven to lower blood pressure. Legumes on the whole, so things like peas, green vegetables, beetroot, definitely have got evidence of blood pressure lowering capacity. Salt, as I mentioned previously, everyone loves salt, but we're not designed for a high salt diet. In the UK and in lots of the Western world, a lot of salt is added to our foods that we buy, in particular cheeses and confectionery as well. But our bodies are designed for a low salt environment. So when you go back 10,000 years, you know, we're based on that prototype of a human, and now in our environment, with a high salt environment, we just can't cope. It puts our blood pressure up, and that's the consequence that we have that we're living with. So if we can avoid foods that are high in salt, if we can't avoid that, then avoid adding salt, and you can use lots of other spices as well to make food more palatable.
Thank you, David. Do we have any? We have room for just one more question before I invite back Dr. Ted to share a couple of resources that will be helpful. So if you have any question, just feel free to unmute yourself, and we can have one of the speakers just answer it.
Hello, I think we'll have a lot of questions after this. Sorry, I couldn't be on the call in the house at the same time, so we had a connection problem. But we've had quite a few people within our clusters wanting to join. We had Shura in Malawi, we had Moses in Kenya. So there's quite a few people on in a different audience and capacity for this call that would have liked to have joined today, but I don't know why a lot of people couldn't get on. So if there's some sort of Q&A follow-up format, we can have this when we share the recording. Yeah, I just thought I'd add that and jump in because I haven't been able to be on the call because of a connection problem.
Yeah, that's good. As mentioned before, this recording will be sent out, and yeah, we'll feel free to ask any questions that you have then, and then we'll have either Ted, David, Christabel, or Robbins just attempt to answer them. Thank you so much, Ted. The floor is yours. I know you have a couple of way forwards for us to kind of take after the call, so feel free to jump in.
Thank you very much indeed. I have to say, I learned a lot of new things myself. I thought I knew most of this, but I have learned some very helpful new information today. So thank you very much for the wide range of thoughts and ideas, importances, preventions, and so forth that we've talked about, and the incredible prevalence of high blood pressure, as we've all talked about, and just about as you showed on that slide, is just amazing. I guess we live in communities in a world where, for many of us, survival is the key thing, and if we just have enough to eat and enough money to just survive, that's really all the sort of social capital we've got for ourselves. And so for those of us who've got choice and can reduce things and can look after our health in terms of NCDs, that's marvelous. I guess what you said, Robbins, was, you know, if we just can have enough food on our plate tonight is the reality for many different groups. But I'm still going to say, I know that's the case, but it's not either or, it's both and. livelihoods and enough food for kids on the plate is essential, but actually so is this for the future of our planet, so that people, as they grow in experience, don't then die and lose all their experience because they don't even know how to prevent themselves from becoming ill in the future. So I think the NCDs to some extent have a sort of amplifying importance worldwide, even though we've got more obvious priorities on our desk at the moment. And I think we need to really emphasize that point. We are working at Arukah and also in an organization I work with called Thrive. We're working on a simple form which can be sent out with information on it, telling you in very simple forms what can be done, and then a form which you just fills in, probably takes about 5 to 10 minutes, and then can be sent back to us. And we will then be in touch with the person who sends it to us on a purely confidential basis. So I just want to let you know that that's in the process of being sort of formatted and has been put together by a variety of different specialists. And we are planning, when we get back in touch with you after this call with further information, to explain how you can receive that and send it back to us. I won't explain the process now. That will be explained to you when we get a call back from Brian after this, hopefully with some more Q&A. So it may take just a few days' time. The key thing when we hear about something is we then do something about it and follow it through. And I'm hoping this piece of information I've just given you, this form and information that we can send out, I think that could be a really great way forwards to help us do it. So I will say thank you again for